Coba berapa suaranya?
Komen di mana?
Oh. Boleh itu.
Nah, tuh, bisa kan tuh.
Kita akan lihat. Tes. Oh.
Jelas, kalau tiga lu.
Keluar di sini.
Wah, jelas. Udah.
tes tes testing masuk tuh hijaunya jangan naik tuh itu kan coba sini hari ini bla 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 cek 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 masuk halo halo testing ojok masuk
Wah,
ini yang mana nanya dong masuk nggak masuk tangan ini profesor nanya dong ini halo nanya boleh ya nanya
Nah, siang untuk peserta rapat, kita akan sebentar lagi memulai menunggu 5 menit lagi. Toleransi.
Any patient from Indonesia?
Patient from Singapore regular.
Regular.
Singapore.
Cek, selamat siang. Pak Suko, apakah dengar suara kami, Bapak?
Ya, saya dengar. Bagus. Apakah suara saya terdengar bagus?
Terdengar ya? Suara kita tidak terdengar. Dari Pak Suko, kita tidak terdengar. Sudah ya. Boleh dicoba lagi, Pak? Suaranya saja?
Tes.
Suaranya kurang terdengar, Pak.
Tes.
Bu Juliana, selamat siang.
Oh,
Selamat siang, Dok.
Bu Juliana lagi di mana sih?
Ya.
Dengar tuh.
Lagi di
Dokter Kartika.
background Rumah Sakit Darmais, Pak di Road.
Baru nyampe. Jauh. Dokter Yudi bisa di depan sana. biar kita bisa mulai.
Kita mulai saja, Pak.
Ya, biar Dr. Andre.
Silakan.
A very good afternoon. We are going to start our lecture today with Dr. Srinivas. It's on proton beam therapy, advantages and benefits. Before we start, I think we would like to ask our director to give overview, Dr. Suko, before we will go to Dr. Devrizal. Ya, selamat siang hadirin sekalian. Hari ini kita akan memulai lecture kita tentang proton beam, benefits dan advantages untuk perawatan kanker. Untuk pertama kita akan mohon arahan dari Direktur kita, Dr. Suko. Silakan Bapak.
Terima kasih. Mudah-mudahan suara saya bisa terdengar ya, Bapak Ibu.
Pak.
Ya, baik. So, thank you. First of all, I would like to thank to Dr. Srinivas Tilukuri for your valuable time. So we have opportunity to learn about your experience using proton beam therapy. And I believe this meeting, the participant is not only from Darmais Hospital, but also we invite some our colleagues from other hospital all over Indonesia. So I think this meeting will be an important and interesting meeting regarding learning about how proton beam therapy is implemented in India. So, ladies and gentlemen, before that, I would like also to thank to Dr. Devrizal and team in Darmais Hospital, and also all participants. Ladies and gentlemen, in the world, we believe that there are hundreds of PBT. 60 of them are developed in United States, and they are now still developing 3 more PBT. In Japan, there are 20 of proton beam therapy, and the other 20 is in Asia and Australia. Indonesia, which have 270 million people, don't have PBT yet. Ladies and gentlemen, of course, we consider about the price of PBT, ability to pay, insurance coverage, and also other challenging thinking about proton beam therapy, including evidence-based medicine with proton beam therapy. And I think it's all true in condition in Indonesia. But ladies and gentlemen, right now the government
Pak
seems.
Suko, suaranya tidak terdengar, Bapak.
Halo, tes.
Sepertinya
kalau gitu.
memang via suara saja. Jaringannya kurang stabil.
Gimana Pak? Kalau sekarang gimana Pak? Halo, Pak Anjari. Oh pas. Halo. Halo Pak, gimana Pak?
Pak Suko?
Ya. Halo. Sampai di mana Pak? Pas ini sinyalnya hilang kali.
Kedengar Pak suara Pak Suko Pak? Jelas.
Kedengeran?
Jelas Pak, kedengaran Pak.
Oh jelas. Oke, kalau jelas saya lanjutin lagi. Tadi sampai di mana ya? Oke, I will repeat. In the world, we believe there are 100 proton beam, 60 of them in United States, and in the United States, we believe they are now developing 3 more PBT, and in Japan, there are 20 PBT. Masih kedengaran Pak? Suara saya terdengar, Pak.
Sepertinya di ruang internasional Pak Dirut yang kendalai netnya.
Oh, begitu. Baik. Kalau gitu, saya lanjut aja ya. Lanjut aja. Okay, so we also consider about the price of the PBT and ability to pay, and also insurance coverage. another challenging thinking about proton beam therapy, including the evidence-based medicine. And this is the real condition in Indonesia. But the government seems have a strong commitment to have this treatment with consideration that Indonesia should have high technology in cancer services. We should have option for people who have cancer and will treat with proton beam therapy. And I think it is in line with human right. We need this technology to catch our delay with other development country. And maybe 1, 2, or 3 PBT seems not too much for Indonesia to have large archipelago and residents. And if we compare with Singapore, which already have around 3 PBT. Ladies and gentlemen, to build proton beam therapy is a challenging situation. If we want to have it now, then maybe 4 years forward, we will implement this equipment. We need 3 or 4 years to make it happen. To implement the PBT. So what we will do now is to understand more about PBT works. How is the evidence-based medicine? What is the real challenging situation? So step by step, we move forward, catching our delay. So once again, finally, I would like thanks to Dr. Srinivas again, who wants to share your knowledge and your experience regarding implementation of the PBT in India. So in the name of good collaboration between both countries, we feel that India always have strong commitment to support Indonesia. Once again, I would like to thanks to Dr. Srinivas and all participants. Semoga pertemuan ini bisa memberikan pencerahan kepada kita semua tentang PBT. Pelan-pelan kita pelajari Bapak Ibu, karena kalau sekarang pun kita berniat mau membangun ini, masih sekitar 3 atau 4 tahun lagi ini bisa terimplementasi. Transfer of knowledge between Indonesia and other country who have already PBT machine or experience will be the first priority from now. Terima kasih banyak Bapak Ibu semua. Semoga semua selalu sehat, tetap semangat, semoga Allah melindungi kita semua. Wassalamualaikum warahmatullahi wabarakatuh. Terima kasih. Mohon maaf kalau ada yang salah.
Thank you, Dr. Suko, for the welcoming speech. Thank you, Dr. Suko, for the welcoming speech. Now I would like to give time and place to our moderator for today, Dr. Dev Rizal, our esteemed senior, to start our program. Dr. Dev Rizal.
Terima kasih Dr. HP. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang, salam sejahtera buat kita. Pertama, tentu kita mengucapkan puji dan syukur kehadirat Allah SWT. Kita diberi kesempatan sore ini bertemu dengan seorang pakar dari Apollo Cancer Center. Excuse me, Dr. Srinivas, I beg you have to speak in bahasa first. Ya, saya lanjutkan. Jadi tamu kita adalah Dr. Srinivas Chilukuri dari Apollo Proton Cancer Center India, dan sebelum itu sekali lagi kita, terutama saya dan tim dari onkologi radiasi Rumah Sakit Kanker Darmais, mengucapkan terima kasih atas perkenan Bapak Direktur, para dukungan dari semua direksi Rumah Sakit Kanker Darmais untuk terselenggaranya acara pada siang hari ini. Dan juga saya berterima kasih tentu kepada our distinguished guest, Dr. Srinivas, to be being here with us to share your expertise in particularly in proton. And sebelum dimulai acara presentasi dari Dr. Srinivas, mungkin saya membacakan dulu sedikit tentang profil Dr. Srinivas. Dr. Srinivas is a senior radiation oncologist consultant from the Apollo Proton Cancer Center. Dr. Srinivas Chilukuri is a skilled and accomplished radiation oncologist who is also a highly sought after speaker in various oncology forums. He has several firsts to his credit. He was one of the first radiation oncologists in the Southeast Asia to develop expertise and experience in volumetric modulated arch therapy technique for pediatric and prostate cancer. He has been the clinical lead for advanced radiation therapy school and has trained more than 200 radiation oncologists from the Indian subcontinent. He has received training in proton therapy from top proton centers of the world like Mayo Clinic, Miami Cancer Institute, and University of Maryland Proton Center, I think all in US. Education, graduation at Armed Force Medical College, Pune after securing all India rank 6. MD Radiation Oncology at Tata Memorial Center, Mumbai in 2004, where he completed his training with a university top rank under the supervision of the legendary Dr. Ketayun Dinso. Joined Yasoda Cancer Institute in June 2008 as full-time consultant, to which he has been associate till March 2018. Publication and awards, more than 30%, 30 recent publication, high impact international journals, have been regular in various national and international meetings as an invited faculty. Among the several awards in 2013, he has received American Society of Clinical Oncology ASCO Idea Award for being among the most promising young oncologists for that year at their annual meeting in Chicago. Successfully organized national level meeting of Indian Society of Neuro-Oncology at Hyderabad with more than 400 delegates. The meeting received reviews for academic format and content. Have been a part of select ICMR panel consisting of around 10 oncologists who have formulated national guideline of management of gastric cancer. Areas of expertise, pediatric cancer, prostate cancer, and thoracic cancer. Sekali lagi, terima kasih atas kehadiran teman-teman sejawat semua dari seluruh rumah sakit, sebagian dari rumah sakit Indonesia yang mungkin tidak saya sebutkan satu persatu, dan juga yang hadir langsung di sini. Sekali lagi, mengucapkan terima kasih dan mohon maaf bila ada hal yang tidak berkenan. Wabillahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh. Berikutnya, our distinguished guest, Dr. Srinivas, the time is yours.
Thank you. Thank you very much. Should I sit there so that I can hear? Should say first. Yes. So first of all, I would like to thank Dr. Defrizal for the kind introduction and for the kind invitation. We have a very long association, and thanks to Dr. Defrizal, I came to Indonesia about 12-13 years back. And that was a time when I was involved in training and helping set up one of the first few private radiation oncology centers in Indonesia. And very satisfying to see that the center is doing very well. I heard from Filda today about it. Thank you very much. And of course, thanks to all the colleagues from Dharmais Cancer Center, the director whom I spoke to some time back, Dr. Soku, and others in the audience. very thank you for the kind invitation. India and Indonesia have been friends for, I think, more than 1,000 years now. I think we have to uplift the legacy of our ancestors, and we will do everything possible to keep that friendship always from strength to strength. I saw some photos of my colleagues, Dr. Badwe and Dr. Vedant, while I was coming into the department. Dr. Badwe is the director of Tata Memorial Center in Mumbai. I was an alma mater of Tata Memorial Center, so very nice to see a strong bond and relation with one of our center. And I invite all of you to Apollo Hospitals in Chennai, which is Apollo Hospital is one of the largest private, in fact, it is the largest private healthcare chain across India. And it has got 14 cancer centers. And so we have wealth of experience, not just from, I speak on behalf of all my colleagues at Apollo, but we have wealth of experience in dealing with cancer as Dharmais also has. And it is wonderful to share our experience with you, and we will happy to hear your experience and learn from all of you as well. Today, the focus, of course, is proton beam therapy, because I am privileged to be part of one of the first proton center facilities in the entire Southeast Asia and Middle East. And that gives me, as I said, an opportunity to share my experience, because it is my duty as responsibility to tell my colleagues and friends and oncology community for the just use of protons, because proton is an expensive tool. And because it is expensive tool, we are physicians are responsible to use it judiciously. And therein comes the understanding the nuances of the technology, understanding the benefits as well as the disadvantages of technology, to ensure that it reaches the right patient, deserving patient, and not everyone who wants it. So if you can load my presentation, I'll be happy to start. So we have now finished almost 4.5 years. We are about to complete 5 years very soon in the next few months. And of course, unfortunately, because of COVID, the 2.5 years, we didn't treat many patients. We did treat during the COVID as well, but we treated very few patients. Last 2 years, we have treated really big numbers, 600-700 patients, I think, we treated in the last 1.5 years itself. And we have, finished the initial 1,000 patients. So can I change the slide? You have a pointer. So just
Bisa next.
express. Sudah, coba itu. This is the next.
Di kita udah berubah slide-nya.
Oh,
Di sini belum. Okay. So as a radiation oncologist, I'm sure there are many surgeons and some medical oncologists and other administrators as well in audience. This was published 3 days ago. Today is 21st July, 18th July. This was published in Express in United Kingdom. And I felt that the statement is very revealing. The radiotherapy is the closest thing to a silver bullet, because it's probably one of the few cancer treatments which is extremely focused. And just to inform all of you, radiation contributes to 4 out of 10 cancer cures. So every government, every hospital, every physician must learn about radiation. And radiotherapy is the most cost-effective of the 3 main cancer treatments, the surgery and chemotherapy, with a typical cost per cure ranging, of course, this is in the context of United Kingdom, but nevertheless, probably can be extrapolated to any country, any context. So you can see the cost per cure ranging from 3,000 to 7,000 pounds. So clearly, radiotherapy is one of the key treatment modalities for cancer, and therefore we all need to learn more about it and learn even advances of this therapy. So, of course, there are many modalities of radiation. We have photons. That is what most of us are used to in our daily practice as radiation oncologists. Photons do not have a charge, do not have a mass. They cause indirect ionization and indirect damage, which is more on the DNA, double strand and single strand breaks. But photons are not, of course, particles, but the rest of the things on the slide are particles: protons, electrons, and carbon ions. Electrons have been in use for many, many years. But electrons are limited by its depth of penetration, and therefore protons and carbon ions are the only particles of interest, which protons, like, as you know, it's positively charged. It could cause direct ionization. Both protons and carbon ions do cause direct ionization, apart from causing indirect ionization as well. And mass of electron, as you know, the reason why electron is so localized, I mean, so limited to the superficial region, is mass of electron is almost negligible compared to mass of proton or neutron. And we all have known about linear accelerator. It has got an electron gun. This electron gun. It has got an accelerator, electron beam transport, etc., etc. But you can see that proton therapy unit, instead of electron gun, we have a proton source. Instead of accelerator, which is a linear accelerator on a waveguide, it's a cyclotron. Instead of electron beam transport, there is something called energy selection system and beam transport. So these are the variations of the proton therapy unit compared to a conventional linear accelerator. And instead of one couch on a linear accelerator, proton therapy has multiple treatments. So one cyclotron can supply proton beams to multiple treatment couches. So this is the cyclotron from where the protons are generated. And this is the beam transportation system, energy selection system. This is the beam transportation system and energy selection system. And this is the treatment room, but not just one, but there are multiple. We have three such rooms. Yeah, three rooms, proton. So proton source is just one, but there are multiple treatment rooms on which treatment can be performed. So how do we generate protons? We generate protons through nucleus of hydrogen atom. It is just comes in a form of small cylinder, and that cylinder keeps replenishing once in a few months, and that some amount of liquid or compressed gas is injected into the cyclotron, and the cyclotron does all the work. Essentially, does accelerating protons. And why do we need accelerating protons? And every time protons are injected they are injected at low energy. As you can see, that protons, 70 MeV protons can cause a Bragg peak at 4 centimeters in water. So it can only treat tumors up to 4 centimeters, but we need much higher energies to treat much deeper targets. And therefore, we need cyclotrons to generate high energy protons. And how do we generate high energy protons? Through particle accelerators called cyclotron or synchrotron. Essentially, cyclo is because it is the orbits in a circular, or it moves around a circular orbit. As the proton energy increases, its orbit radius increases, and high energy protons are kicked out. And that is how these are commercially available cyclotrons, which we are using IBA, but there was a variant cyclotron as well, which was available a few years back. There is also called synchrotron. So many Hitachi-based facilities are synchrotrons. There are advantages and disadvantages, minute advantages and disadvantages. I'll not go into the details, but essentially, cyclotrons release high energy protons, and they have to be deliberately degraded to make what energy we need to use for a patient treatment. Those energies are generated as the proton beams are transferred through energy selection system. So this is the beam transportation. It's a very lengthy corridor. And we have something called pencil beam scanning proton beam therapy. We've all heard of Bragg peak. I think I should have, I think slides got jumbled up a little bit, but I'll come back to the slide. Yes, so this is a Bragg peak. So for non-radiation oncologists, X-rays are attenuated. They don't have a mass, they don't have a charge. They deposit maximum energy within a few millimeters below the skin, and they get attenuated. Attenuated means the intensity of X-rays come down. But protons do not deposit energy immediately after entering the skin. They travel a certain distance and then release their entire energy and literally stop. Because they stop and they deposit their entire energy in one go, it is called a peak, because after a peak, there is nothing. So there is nothing beyond this peak. And that is the difference between X-ray, which is in the gray, and protons, which is in the orange. So you can see that X-rays don't stop. They get attenuated, the intensity comes down. That means the dose comes down, but the protons stop. And what we are doing with pencil beam scanning, can you go back a few slides, please? Yes. Okay. One more slide. One more slide. One more slide. Yes, that's it. That's it. So what we do with pencil beam scanning system is that these, you can see these Bragg peaks are deposited within the tumor. Spot by spot, you can see again it is going to come spot by spot, layer by layer, from the deepest layer to the most superficial layer. So this is spot which has come, which is a Bragg peak, deposits entire energy. And similarly, there is many more Bragg peaks from deepermost layer to most superficial layer. And you can see that while the energy is deposited here in the tumor, there is absolutely no dose around the tumor. There is some dose before it enters the tumor, but there is nothing beyond it. And that is the difference between protons and conventional radiation. You can see the treatment room. You can see someone standing here. It's a 3-storied pit, a huge pit. And we have 3 such rooms. So this is one just treatment room. Because there is no exit dose, you can see this is proton plan and this is normal radiation, IVMAT plan. You can see the high doses are restricted to the tumor, but the low doses cover entire body. But you see the protons. High doses are restricted to the tumor, but the lower doses stop because there is proton stop. You can see the rectum is not receiving, the circumference of rectum receiving no dose. The femoral heads, the bladder receiving absolutely 0 dose. And that is the difference between conventional radiation therapy and proton beam therapy. So, as I said, photons causes attenuation, protons, no attenuation, it stops. And because of its stoppage, the physical advantages of protons are present. But there are not just physical advantages, but there are some biological advantages as well. And there is something called RBE for radiation oncologists among the audience, something called radiobiological effectiveness. And potentially, protons, radiobiologically, they are more effective than X-rays. So theoretically speaking, if there is a sarcoma, if there is a tumor which is more radio resistant, which may not be amenable to control with radiation, protons may be a better modality compared to X-rays. And therefore, in adenoid cystic carcinomas, in sarcomas, in re-radiating tumors, protons seem to have a better advantage, more edge than compared to better edge compared to conventional radiation. So the benefits of protons theoretically are physical advantage because of the Bragg peak, sharp distal fall off, better normal tissue sparing, but there are biological advantages as well because of the dense ionization, because of high LET, linear energy transfer, and higher efficacy in cellular kill. So these are the benefits of proton beam therapy. Now we know the 2-dimensional radiation, we know the 3D CRT, we know the IMRT. IMRT is also very good. But you see the low doses, intermediate doses all over the place. So that is the difference. And therefore you see, this is the VMAT, this is the tomotherapy, and this is proton beams, where you can see a lot more normal tissue sparing compared to conventional radiation. So if you compare this in a patient who is a child who is receiving helical tomotherapy for something called craniospinal radiation, for say medulloblastoma, ependymoma, germ cell tumor, etc., you can see that the low doses are received by the oral cavity, the mandible, the thyroid, the heart, lungs, kidney, bowel, gonads, bladder, everything is receiving some amount of dose. Compare this to protons, where you can see beautiful sparing of all the anterior structures, all these heart. I can tell the parents of this child that the heart of the child will not receive any radiation. So that is the benefit. Similarly, for lung cancer, you can see big difference. Now, the heart and lungs receive significantly less doses with proton beam therapy. I don't have to write which is proton and which is normal radiation. I think you can imagine. Same for prostate cancer, same for brain tumors. You can see brain tumors as well. If you are irradiating this, rest of the half of the brain does not receive any dose of radiation compared to most of the brain receiving some amount of radiation. So these are all theoretical advantages. Now, let us literally, as the director mentioned, what is the evidence? And there are many challenges in evidence generation. I have published, 3 years back, how we can collaborate to generate evidence, because it's not easy to generate evidence in protons, especially when it is so expensive. People, if there is a huge benefit with protons, they will not be willing to get randomized, participate in randomized trials. How can I ask parent of a child to participate in randomized trial when proton therapy could be significantly beneficial? So although this can be critiqued either ways, but it is really difficult, even in North America, where there is some culture for clinical trials, pediatric cancers and many other cancers, randomized trials is not possible. And therefore, we need to think more innovatively how to generate evidence. And I will summarize some of the evidence in the next few slides. There are ongoing randomized trials for breast cancer, for brain tumors, for lung cancers, for prostate cancers, for esophageal cancers, for hepatocellular cancers, for low-grade gliomas, for head and neck cancers. Although these are all active and they'll recruit patients over next few years, we will hear the results after 5 or 6 years from now. But it doesn't mean that we cannot treat patients now, because there are some patients who benefit immensely with protons. So, but we need to think judiciously. Why? Initial setup cost of photons, if it is X, protons is 15X. This is for single loop. Maintenance cost, if it is X for photons, it is 12X. Electricity costs, if it is X for photons, 10X for protons. Similarly, throughput, despite all these costs, is half of the conventional radiation. Manpower requirement is also more, and therefore we need to learn when and where we should use it. For oncologists and physicists in the audience, the imaging, the pre-planning checks, the target delineation, planning, plan evaluation, quality assurance, all these steps which we normally use for treatment, also with protons, is much more than what we do for. So the amount of physician hours, man hours, or the workforce hours spent are also significantly higher. And therefore, we need to understand where are the clinical indications of protons. And just tell you the size of protons. You cannot build make a building and then bring the proton machine in. It's not possible. You have to get the proton machine in and then make a building around. It is such huge. The electricity costs, the maintenance costs, the amount of maintenance costs Apollo hospitals pay for protons is equivalent to 1 LINAC every year. Almost. May not be higher, but a good LINAC, which can do good IMI. And therefore, we need to think really hard when and where and how it should be used. And therefore, my next few slides will come to that particular aspect on how we have used Proton so far. Of course, I'm not saying ours is the perfect way to choose, but this is something which we have done. And we are learning. And as we learn, we know that, okay, that there are better indications of protons. So when and where is Proton used? 4 situations. 1, when the target volume is in close proximity to any critical structure and results in underdosing the target, where if I have to give high doses to the target, I have to underdose the tumors. There are many such situations. There are skull-based tumors, paraspinal targets, pancreatic tumors, retroperitoneal tumors, chordomas. So these have been the biggest indications. Chordomas anywhere. I treat chordomas, all chordomas in our center. And I get patients from North America, South America, Europe, Africa, Far East, Southeast Asia, India, from all corners of the country. If it is a chordoma, they don't have an option. They have to go for any proton facility. Either they come to India, they go to another proton facility anywhere else in the world. So chordomas, there is a big benefit because the control rates are significantly better with protons compared to conventional radiation, especially in difficult locations. The second indication, increased clinically meaningful normal tissue toxicity. That means with photons in children, when we are giving low doses, even low doses causes toxicity. Pediatric cancers, benign brain tumors, because if it is say a meningioma in a young person, 30-year-old meningioma, the person is going to live for next 70 years or 60 years if it's healthy. And we are giving radiation toxicities to a very young individual who's going to live for the next 60 to 70 years. So are we justified in giving toxicity? And now we have to think hard. So therefore, benign brain tumors, craniospinal radiation, large complex targets, again, could be head and neck cancers, could be many other cancers. Photon plans are prohibitive. I'll show you a few cases in lung, where if we have to give very high doses to the lung cancer, I have to give a higher probability of toxicity. It is prohibitive. Sometimes we say concurrent chemoradiation not possible. Let's do sequential because this patient will not be able to tolerate it. So thoracic radiation, mesothelioma, thymomas, etc., lung cancers, hepatocellular cancers. So coming back to the data, there are very few randomized trials. I told you the reason why. It is very difficult to accrue. Randomized trials are expensive. I'm not saying they should not be done. They should be done, but it has been very challenging in the last 30 years to do randomized trials in protons. But there are a good number of cohort studies, and there are several treatment planning exercises which demonstrate dosimetric benefit. But dosimetric benefit is not equivalent to clinical benefit, and therefore we need more prospective data. So how do we select patients? So we have an informed decision making. We have a diagnosis clinical indication list in our facility. We do a multidisciplinary team consensus meeting, like a tumor board on a regular basis on which we decide. Of course, the cost also comes into the factor whether the family can afford the cost and how can they organize cost. Some in children, we have treated many children free of cost by raising funds through a crowdfunding to make sure that patients are treated. Similarly, dose comparison methods, there are many other dose comparison methods. These are time intense, subjective, a lot of uncertainties, but these are some of the more objective ways to treat than just informed decision making. And we do use all these methods to select patients for proton therapy. But American Society of Radiation, it cannot say that proton therapy is standard in this patient or that patient. Why? Because there are only limited proton facilities across the country in the United States. And therefore, they have given a guidance document for patients to be reimbursed for proton therapy. So group 1 is disease sites that frequently support, and group 2 is coverage with evidence development. If the patient is part of an approved clinical trial or multi-institution patient registry, the insurance can give approval. So group 1 are malignant and benign central nervous tumors, advanced unresectable head and neck cancers, paranasal sinus cancers, retroperitoneal sarcomas, re-radiations, ocular tumors, tumors that approach are located at the skull base, spine, children, genetic syndromes. All these are group 1 indications. And of course, these are chordoma, chondrosarcoma, retroperitoneal sarcoma, skull-based tumor. So all these are re-radiations also. Advanced head and neck cancers also, hepatocellular cancers. So these are some of the group 1 indications. And our experience is also very similar. 80% of our patients we have treated so far belong to brain tumors. They are pediatric age group, either brain or otherwise, head and neck and skull-based tumors, and musculoskeletal and bone and soft tissue. So 80% of the tumors belong to these 4 categories of patients. We have treated patients of prostates. We have treated patients of lung. We have treated patients of GI cancers and gynecological cancers, but majority of the patients belong to these indications. There is some connection. So for pediatric cancers, almost all of them are related to either intracranial tumors or extracranial tumors. We have treated all patients. The youngest patient we have treated was a 10-month-old baby, and the oldest we have treated was 80, 87, 88-year-old. But pediatric cancers, to tell you a few, we have treated almost all, and easy to convince all of you for why we should consider protons, because almost all late effects are dose dependent. And late effects do not appear in tissues or organs that are not irradiated. So if I spare heart, how will it cause late effects? So therefore, you can see, if I spare heart in this patient with proton therapy, it will not cause late effects. So that is the beauty of proton therapy. And similarly, if this is a child who can have, say, I'm treating the vulva and vagina, then the patient will have permanent sexual dysfunction forever, this child. And if you're able to spare with protons, you can see photons compared to protons, and you can preserve these functions. And therefore, in children, it is extremely crucial to consider protons. I think if the indication for in Indonesia is children is a big number, reasonably big number, then it is automatic justification why Indonesia should have this. And there are many benefits. I'll not go into details. We have published as well the quality of life in children and brain tumor survivors with proton beam therapy is definitely better. I have published a preliminary experience of treating children and young adults with image-guided proton beam therapy. This was published again 2-3 years back, and we have treated about 50 children initially. And we saw that the results were quite encouraging. We've also published our outcomes on craniospinal radiation for a variety of tumors, medulloblastoma, germ cell tumors, and etc. And we found, again, a very good result in these patients, including an audit, critical appraisal of our techniques as well. This was a child who had a history of acute myeloid leukemia. When the child was 5 years old, patient underwent bone marrow transplant not once but twice, and later developed rhabdomyosarcoma in the, you can see in the upper abdomen and chest. Had multiple complications previously. 5 years later, rhabdomyosarcoma. And we have treated this patient with protons. You can see we have spared the heart beautifully compared to conventional radiation, where you could have given a significant amount of dose to heart. Similarly, brain tumors, as I showed you, has been one of the key areas of focus at our center. And we have treated all these brain tumors, both pediatric and adult, both benign and malignant tumors have been treated at our center. Intracranial germ cell tumors is one of them, whether we treat whole ventricle or craniospinal. We have seen excellent results. You can see that one of the child who underwent whole ventricular radiation after 2 years scored 593 out of 600. I don't know why the 7 marks she lost, but she stood third in the district. We've also treated ependymomas, again, very, very, I would say very appropriate indication for protons across the world. And there are outcomes encouraging, a lot of studies have come. You can see 179 children with ependymomas have been treated in this study, which showed very encouraging outcomes, and we would strongly recommend for a good number of patients of ependymoma proton beam therapy. Similarly, for pediatric low-grade gliomas and pediatric high-grade gliomas, not just in pediatric age group, but in low-grade gliomas, there is now a randomized study between Proton versus IMRT. And similarly, for high-grade gliomas, GBMs as well, there is now a randomized trial underway. Maybe we'll have an answer after 3-4 years. Coming to skull base head and neck tumors, we treat skull base, periorbital PNS tumors, paranasal sinus tumors, mucosa sparing and re-radiation. These are the 4 key indications in head and neck cancers. And you can see one of the large paranasal sinus tumor, elderly man with multiple problems. You can see extensive lesion. And despite that, we've treated beautifully. You can see the difference between proton and conventional radiation. So much of normal brain is irradiated. And this patient at presentation was like this. And you can see after 8 weeks itself, there was complete response, no avidity in maxilla and ITF. Similarly, adenoid cystic carcinoma, I mentioned these are radio-resistant tumors. You can see beautiful response after proton therapy. These are, again, very gratifying tumors to be treated on proton. Similarly, salivary gland tumors, again, another group of radio-resistant tumors also benefit with proton. You can see this is proton, this is IMRT. Again, this is IMRT and this is proton. You can see the rest of the submucosal gland, contralateral parotid, rest of the contralateral mucosa significantly spared with protons compared to radiation. You can see the difference. You can see that normally we don't see at 26 fractions of proton therapy, we see a lot more reaction, but you see that the reactions are quite limited in patients such as these who are treated with protons. I treat musculoskeletal tumors. I think this is very gratifying patients to treat. We have treated a large number now. You can see this is one of the large, I would say XXL size chordoma, huge sacral chordoma. Patient was walking, you can see this. And we treated with protons only after biopsy. And you can see serial shrinkage of the tumor. And you can see now, you can see a small tumor now left. So, we have treated now almost several such sacral chordomas in the past. Similarly, osteosarcomas. These are not indications for radiation at all. But in situations where surgery is not feasible, in vertebral, in pelvic, in skull base, lesions, proton therapy works. We have, you can spare the bowel, ovaries, other pelvic structures. We have given sometimes even concurrent chemotherapy for many patients of pelvic osteosarcomas. It is possible to do that. And again, saw some gratifying responses, even including patients with tumor thrombus. I don't know whether any orthopedic surgeon is there in the audience, and they would appreciate that, you can see the tumor thrombus becoming more bland after we treated the thrombus as well. In this, and you can see the complete response in thrombus as well. We've treated many such osteosarcomas, and you can see very good responses from these patients. Lung, I think, again, this illustrates why proton therapy could be beneficial in lung cancers. This is a 63-year-old gentleman with squamous cell carcinoma, T3N3M0, diabetic, hypertensive, weighs about 120 kgs, requires intermittent oxygen. This is the PET, of course, had a T3N3M0. Why N3? Because contralateral hilar nodes were positive, and therefore it was N3. And when the radiation oncologist at Mumbai, planned him for IMRT, he saw that the V20 was 36%, and despite deep inspiratory breath hold, everything possible in a 120 kg with the cardiac morbidities, 36% looked very, very frightening to radiation oncology. He said, let's not give concurrent chemoradiation, let's give sequential, because we will not be able to respect those constraints. And it is a prohibitive plan. And therefore he said, why don't you consider for protons? And we saw this is the protons. You see the difference. Heart mean dose coming from 30 gray to 7 gray. The lung V20 coming from 36% to 22%. V5 62% to 35.5%. So dramatic reduction in the normal tissue doses. You can see that this is the indication why, you can see this is protons and this is IMRT. You can see amount of lung which is spared beautifully well with protons. And this is, again, a very good indication for protons if such a patient enters your clinic, and probability of grade 3 toxicity is significantly reduced. Now, prostate cancer has been, well, I would say protons have been abused in the United States for prostate cancers. And protons has attracted a lot of, bad name, because a lot of prostate cancer patients have been treated with protons, but not the appropriate indication. In US, majority of them were low risk, intermediate risk, prostate confined. But what we see in our country are, high risk patients, not detected on screening. They are locally advanced, and we feel there is an advantage with protons in them as well. And we embarked on this study. This we published in International Journal of Particle Therapy 2 years ago. We saw the dramatic reduction in the doses to rectum and bladder compared to normal radiation. And you can see based on that, we estimated that late toxicity could be reduced. GI toxicity could be reduced by 17%, and GU toxicity reduced by 11% in terms of fecal incontinence, bleeding, stool frequency, maturia, dysuria, urinary incontinence. So all 6 domains, we felt that we saw that there could be reduction in the toxicities, especially in a vulnerable patient. One could consider protons in these patients. We are now routinely, because thanks to the reduced cost, because we are treating only 5 fractions, like we treat prostates nowadays with photons, 40 grain 5 fractions, or 37 and 5, 36.25 and 5. We are treating the same with protons with a dominant intraprostatic lesion boost. And the cost of protons has come down significantly now, because thanks to this technique, and we are able to treat a lot of prostate cancer patients now within 1.5 weeks of treatment. Now all prostate cancer patients are being treated in a ProCube registry study. I am the principal investigator. We are maintaining a prospective database to make sure that we choose the right patients for proton beam therapy, and not any who walks in and asks for protons. There is now a randomized trial supporting the use of proton over photon for esophageal cancers. And what they showed was the total toxicity burden was significantly reduced in patients treated with protons compared to conventional radiation therapy. This is a randomized phase 2 trial from MD Anderson Cancer Center. Similarly, we have treated a lot of liver tumors, pancreatic tumors, very, very gratifying. So coming back, and I am ending my presentation with these 2 slides. Again, I mentioned when and where is proton used. I have summarized all these, and I have shown you all these aspects. But in a country such as India, I'm sure Indonesia as well, the similar, you can think, a low and middle income country, one wonders, is proton therapy such an expensive tool? Is the need justified? Right? And this I have published again 2 years back in the Journal of Clinical Oncology, Global Oncology. And we argued in the commentary that it is an engineering marvel, which is certainly of great benefit for a few, incremental benefit for some, and maybe of not much benefit for many. But patients who are likely to benefit with this technology, irrespective of their country of residence, must be able to access this relatively easily and at a reasonable cost. And that is the bottom line of any technology, right? And it is important that access is important. That means we need to make sure that the last mile, people from last mile are also able to access it. But it is also important to timely adopt new and modern technology, because our patients deserve it. And access and timely adoption should not be parallel goals, should not be mutually exclusive. They should be complementary goals. We should work on getting more linacs, but we should also work at getting big technologies as protons for the benefit of patients. So to conclude, we have treated now more than 1,000 patients. We have promising preliminary experience. We have multiple sites treated, almost all sites treated. The data is being collected prospectively. The acute toxicities are low, large percentage of recurrent and re-radiation patients. As the footprint of the technology comes down, it becomes more and more compact. The cost is likely to come down. There are several randomized trials are ongoing. We are also generating prospective data, and hopefully for future centers, maybe one in Dharmais as well in the future, hopefully we will be able to share our experience, and you will have more data to inform your patients who will benefit and who will not. And of course, this is our team. And not just this team, I think there are people behind this as well, the administrators, marketing staff, everyone else who have contributed to this facility. And as I said in the beginning, I would like to welcome any of you, all of you who would want to come in India and visit our center. We'll be very happy to show you around and give a glimpse of our center and what we do in Chennai. Thank you very much for this opportunity.
Thank you very much, Dr. Professor now, Professor Srinivas, and very excellent and comprehensive presentation. I think, yeah, we can more understand about the proton therapy. And next, we are going to question and answer. Any question from the audience here or from the ada berapa question? Yeah. Thank you. Any questions?
Yeah, I can read that question. I think it is from a neurosurgeon, I guess.
Yeah.
So, yeah, so Dr. Singh, thank you for the question. Very interesting question. Is there any age restriction for proton beam therapy? I think for any child, the key thing should be to, if possible, can we avoid radiation altogether, any form of radiation altogether in any child? But if a child, if the child is going to benefit from any radiation, I think all of children whom we feel would benefit with radiation therapy should be considered for protons. Age restriction in children's oncology group in North America, now most children who have a posterior fossa tumor who are older than 6 months and a supratentorial tumor more than 1 year are considered eligible for radiation therapy. Of course, these are exceptional situations. These are situations such as ependymomas, atypical teratoid rhabdoid tumors. These are indications wherein we could, use proton therapy for very young children, less than 3 years old. But the cutoff is now 6 months for posterior fossa tumors, 1 year for supratentorial tumors. The second question is any role of PBT in glioblastomas? We have treated certain glioblastomas, epithelioid GBMs, young patients with epithelioid ones are the ones who can survive much bit longer. MGMT methylated ones, good surgery in a good location in a young patient could be considered for protons. Some re-radiations also we have treated. As I said, there is a clinical trial, randomized clinical trial underway. We would not routinely recommend protons for a GBM patient for sure, because we know the reasons. But we have done in certain situations, exceptional situations, to build our experience. Any limit of number of radiations that has been given to patients? Well, we have treated 2-3 radiations with protons, of course, not in the same site. I think there's no point irradiating too soon as well. unless we document that there is a substantial response by means of response evaluation because of the first radiation, there's no point repeating another course of radiation. But in general, yes, a lot of re-radiations. I mean, 20% of patients we have treated are patients who required re-radiation, whether it's head and neck, whether it's spinal tumors, whether it's lung tumors, etc., etc. So, yeah, thank you.
Okay, any more questions? From the left here? Any question?
I have a question.
Sure.
Thank you for the excellent presentation, and this is a new knowledge for me. I'm a GP at this hospital. My question is, what about the quality of life of the, you said that the pediatric patient and then the older patient, and then the a patient with the obesity that have lung cancer, how about the quality of life of after they
Actually, somehow that patient is still alive. A lot of people ask about him because whenever I make a presentation, he's still alive. He's controlled, and he's one of our biggest ambassadors, Protons. He's a patient advocate. He gives a lot of patient interviews. He writes in the press. He's a very big advocate, not just for proton therapy, but also for immunotherapy. He also took durvalumab, which is a standard of care now post chemoradiation. So I think if we reduce the toxicity, theoretically, there is an opportunity to improve quality of life as well. And we know that. I mean, as I treat prostate cancers, I treat children, I treat thoracic cancers, I treat sarcomas. I can clearly see that there are patients where there could be distinct advantage as far as the quality of life is concerned. We have published for children less than 4 years, but there are patients in adults as well, in adolescents and young adults, AYA population, who also could benefit significantly with protons as far as the quality of life is concerned.
As I know that the thoracic cancer patient, after they have the radiation, their lung will get fibrosis. So what about the after they have the proton?
So same thing happens with protons as well. But the proton beauty is that it doesn't irradiate the most of the lung because it stops. And because it irradiates very little lung, only that portion of the lung is partially fibrosed. And therefore, the normal lung is spared as much more than conventional radiation. In fact, I can show you, some of the patients whom we've treated like SBRT as well in interstitial lung disease. Patients who could have a lot of fibrosis after conventional radiation. We have used protons in them. We have treated safely, and we have avoided all those complications of lung fibrosis.
And what about the breast cancer patient? They also get radiation.
Yeah.
So the lung.
So I'm sorry, I did not put any slides on breast cancers. It is interesting. We have treated about 20 odd breast cancer patients, mostly patients who are left-sided breast cancers, and wherein we are treating regional nodes such as internal mammary nodes, where if you use conventional radiation to treat supraclavicular, internal mammary, and young patients, we will be treating a lot of heart, a lot of lung. And therefore, they can be considered for protons because protons are beautifully cardiac sparing. And in US, again, I don't necessarily agree with it, but number one indication of proton today is breast cancers.
Wow. In US.
Well, again, I would say I don't agree with it, but well, they are generating data to be fair to them. They are generating prospective data. There is a randomized trial also, and breast and lung, number one and number two sites. And yes.
Okay, another question from the audience or the church. Yeah.
So every talk has to end with the question on the cost. It never can it can never be finished without.
That's it.
So, but and then as a clinician, as a physician, I am really embarrassed to talk about the cost. But nevertheless, it is important for our patients. So the cost would vary between 15,000 US dollars to 60,000 US dollars, depending on the number of fractions, the complexity of the treatments, requirement of anesthesia during the treatment, etc., etc. So 5 fractions, it is less. More fractions, it is more. More complexity, it is more. Anesthesia, it is more. So something like that. So between $15,000 to $60,000 for the entire course, not for one fraction, for the entire course of treatment.
Complex.
Okay, sorry.
Yeah.
Thank you. We will again.
Dr. Nico. Dr. Nico.
Yeah. Scanning.
Now I think there's a question. Is this different in learning from transition from photon MRI proton from radiation?
Very nice. Very nice. I showed that slide, simulation, adaptation, repeat imaging, quality assurance imaging, planning, contouring, target delineation, plan evaluation. At every step, there is a learning curve. At every step, the duration of the man hours which people have to spend for all these steps is far more in protons compared to conventional radiation. Pencil beam scanning is extremely sensitive to depth changes. So if half a centimeter depth is changed because the patient has lost 1.5 kg weight, in photons, it wouldn't perturb the dose so much. You wouldn't bother. Half a centimeter. But with protons, half a centimeter could make a big difference. So you have to be on high alert throughout the treatment. At any point of the time, you see there is changes. There is, you have drawn a target and you have marked the OARs. OAR were gassy because the bowel was empty and it was all gassy. And now it is collapsed. The protons would skid more because the range, protons are range dependent. So it is so much more complex and there is a big learning curve with protons, no doubt. And now we are fortunate to be one of the very few training facilities. There are only 2 or 3 IBA, which is one of the market leaders. We are one of the training centers for IBA school. So you're right. It is extremely complex, and therefore there is a big learning curve compared to.
So you do adaptive plan every.
Yes. So now about 25 to 30% of patients require adaptive plan, sometimes more than once.
Okay, thanks, Dr. Arfi. Thoracic surgeon.
As a surgeon myself, just like Dr. Singh, I'd like to ask, with lower risk, better quality control of life, in your MDTs, do you see a shift of the amount of operations surgeon do? Because with the longer life expectancy, then there will be more cases for us to do with biopsies and all. Is there a significant shift when I think you should see a lot more in pediatrics if that is the case? And second of all, when we talk about, we're saying we need to talk about cost. In your experience, using one cyclotron and creating 3 different, so that make your return on revenue faster? And how much electricity will you save because we're planning to build one? Are we going to go just one treatment, or is it going to be beneficial?
So that is a very good question, and there are some calculations. There is some literature about what is the optimum mix of rooms per cyclotron. It seems to be 2 are the right balance. 2 rooms are the right balance for one cyclotron to use it effectively and yet use it for a significantly large number of patients. again, return on investment is a very contextual thing. It varies depending on you are talking about North America, if you're talking India. I'm sure Indonesia would be different compared to India. Singapore would be different. So, return on investment is a very contextual thing. In India, almost all patients are paying out of. So there is no, approved insurance. I mean, now, of course, private insurances have approved for Proton for many indications. We have to write a detailed justification letter saying that why Proton is required in this patient. And if the insurance panel of doctors agree with us, they approve the indication. And more often we get, because we are treating those selected patients. So in Indonesia, how is it going to be? Again, the same, whether insurance will reimburse or not, how much. So it depends, and especially in National Cancer Center, I'm sure it's a public hospital. So I think in a public sector, in countries such as Indonesia, big countries like Indonesia should have a program, because there will be many children, many deserving patients who are easy indication for programs, and there is no controversy about it. Because UK, before they set up their facilities, they were referring many patients to United States. And some of them were children, some of them were sarcoma, some of them were skull-based tumors, chordomas, etc., etc. But once you have it, you will have those lung cancer patients, you will have those other patients who are vulnerable, who would also benefit with programs. When we see there is a big advantage, why don't we use this technology? Number three, you will also, in a public hospital, it is onus on you, and one of the mandates for you to do is research as well. So to understand which of your patients, because America will not do research for our patients. We have to do research for our own patients who will really benefit. And Indian, prostate cancer research, whatever comes from North America, will be all low risk screen detected prostate cancers. Those are not relevant for us. So I think oral cavity cancers, because tobacco consumption is huge in India, a lot of people come with oral cavity. In fact, we have a huge epidemic of oral cavity. No one is going to analyze oral cavity. They're going to tell us about oropharyngeal cancers. So we need to have research for our own patients. And I think Indonesia will also think in the same lines compared to other countries.
Any more question? Yeah, Dr. Kartika is our radiation oncologist.
Thank you. Question.
Sure.
First, in conjunction with the Ferhan, if you do the therapy in general, what is the ideal specification of which it's number two, I know that there's a lot of benefit and there's also high cost of maintenance. I would love to ask that, do you have any other plan or income source of income other than propagation to regulate the monetization regarding?
So both are good questions. The first question being, you said, what is the specifications, machine specification? It's a very important question, which I have not covered in my talk because of the paucity of the time. 2013 or 14, the chairman met me, chairman of Apollo Hospitals, Dr. Pratap Reddy, who's a cardiologist, a very renowned cardiologist who's considered father of private healthcare in India. He met me and he told me that protons, they are interested in acquiring protons, and I told him that I'll go for training and see if I join. And I went to MD Anderson Cancer Center. I went to a few other major cancer centers in the United States. I was disappointed to see there was no image guidance. It was passive scatter. And they used to give large margins. Compared to photons, we are giving 3-5 millimeter margins. They were giving large margins. And that was because they were giving large margins because there was no image guidance. I also went to Japan and visited Proton Center. The algorithms which they were using, and we were using Monte Carlo and Monte Carlo-like algorithms. And in Japan, the PhD student has written his thesis And they're using some homegrown treatment planning system with very primitive algorithms. That is why we see the results of protons are not so good, because we were using primitive algorithm, primitive techniques, large margins, no image guidance. Can we imagine in the today's world treating all tumors without image guidance? And therefore, we see that the optimal advantages of protons have not been utilized in the past. And therefore, it is important that specifications, that question comes, what is the specification? I think it should be pencil beam scanning, it should be image guidance. Cone beam CT has to be there. And it has to be, if you are treating moving targets, lung, liver, pancreas, other upper abdominal tumors, there has to be some kind of a respiratory management, RPM or a surface guidance or some kind of thing there. If feasible, we should have a dedicated CT, because a lot of adaptive patients require a lot of adaptive replanning. So dedicated CT scan, CT simulator would be ideal. As I mentioned, 2-room solutions with cyclotron would be good. There are differences between synchrotron and cyclotron. For example, Hitachi supplies synchrotron, ABS supplies cyclotron. There are some advantages of cyclotron because energy switching time from, every patient will be treated with 230 MeV to 100 MeV. So each patient will require 100, 120, 130, 180, 200, 220. So multiple beam energies are there. And therefore, we need to switch energy from one layer to another. One layer will receive 200, then other layer will receive 180. So that energy switching time has to be fast for the treatments to be very efficient, right? Linear accelerators. And cyclotrons provide that energy switching time, which is very, very short. So I feel the best combination is cyclotron, pencil beam scanning, cone beam CT, surface guidance, or some kind of a respiratory motion management strategies, and image guidance, of course. So these are the specification by and large. New machines are coming where cyclotron can be mounted on the gantries. So it is, instead of being a huge complex, initially I saw Loma Linda. It's like a football field, it's huge. Now we don't require that much amount of field, but still the facility is quite. I think with such innovations, hopefully program will be a lot cheaper. The second question I forgot.
I think our data could be beneficial also.
Yes, MR Linac. So MRI, there are now active. Some companies are looking at integrating MRI with. I think it will be too far-fetched as of now, but it will happen. It will happen for sure. And see, if you remove the cost out of the equation, many more patients would benefit with problems. So if you remove cost out of the equation, but it is hard to remove cost out of the equation because cost is an integral part. So unless the cost of the proton facilities come down, it will not become routine. So when it comes down, then integration with MR, integration with PET will all happen. I feel it will happen.
And second question was, do you have any other source of income?
We don't. Unfortunately, some US hospitals are getting some amount of research funding for. We have a room which is not optimally utilized. So we have 3 rooms. 2 rooms are fully full. 3rd room is not very full. So we can use it for research, but unfortunately, research scholars should not be paying a lot of money to get time in the room. I think, but anyway, that is another scheme, another income stream which can. But I don't think that we are not at that point.
Ada pertanyaan dari Pak Dirut?
Ya.
Prof. Dr. Supa.
Ya, Prof. Presiden Besar, apakah ada pankreas bisa di-treat dengan PBT? Is there pancreatic cyst?
Not really. Pancreatic cyst could be benign, pseudocyst. I don't think we would treat them with any radiation therapy, I think. And therefore, protons. We have to extrapolate the utility of conventional radiation. So first we have to ask, is conventional radiation required in pancreatic cyst? If it is yes, then can it be delivered well and safe? Then we don't need any therapy. If it cannot be, or it's a vulnerable patient who can develop much more side effects, then probably yes. So I don't think we routinely treat pancreatic cysts with protons anywhere in the world, and we have not treated even a single patient, but we have treated pancreatic cancers with proton beam therapy.
Thank you.
Thank you.
Yes. Commissioner. Is there any question more? Sudah cukup. Baik, thank you very much once again, Dr. Srinivas, Professor Srinivas, and very exciting as it's a great honor for us for being here today, and hopefully more extends to in the future. Sekali lagi para sejawat, terutama Pak dari dari Direksi Rumah Sakit Kanker Darmais, terutama Dr.
Boleh
Suko.
sedikit.
Ya, silakan Dr. Suko.
Ya, sedikit saja, Dr. Dev, terima kasih. So, as the first proton beam therapy services in Southeast Asia, I believe that you have experience, and maybe for Indonesia who just begin to start development PBT, if you have experience any aspect to make PBT in Indonesia in the future more effective and efficient. So with your experience, we believe that you can suggest the strategy to have PBT in Indonesia. That first impression for this meeting. The second is right now Indonesia, we learn from many center of proton to decide what kind of PBT machine. So we learn from India, Japan, Europe, United States, Taiwan. So I believe that this meeting is just a start to learn PBT for the future. So once again, thank you so much for your valuable time, Srinivas. And I believe that our team in Indonesia will learn to your center in India, and also comparing any effective and efficient strategy to develop proton beam Indonesia. Terima kasih banyak Dr. Dev dan teman-teman semua. Selalu semangat nih, kita baru mau memulai, jadi kita pelajari dengan baik dan betul, karena pemerintah kita sudah sangat berkomitmen. Tentunya tidak ada kata lain selain kita berusaha untuk bisa memberikan yang terbaik untuk negeri ini. Terima kasih dari saya. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Dr.
Terima kasih semua hadirin pada sore siang ini. Mudah-mudahan apa yang telah disampaikan tadi bermanfaat bagi masyarakat, khususnya pasien-pasien kanker yang membutuhkan terapi spesifik, tidak hanya konvensional radiation terapi, tetapi juga yang lebih spesifik tentang proton yang bermanfaat bagi kepentingan pasien kita. Kita ucapkan terima kasih, alhamdulillah atas pertemuan hari ini. Mohon maaf apabila hal-hal tidak berkenan. Wabillahi taufik wal hidayah. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Terima kasih.
Share videonya.
Sekarang kita akan memberikan sertifikat dan juga plakat. Mungkin Dr. Dev dan juga
langsung olahraga. Sini saya. Oh, sini. Sini Mas. Sini dong. Oh,
Thank you, friend.
Oh, yeah. Besok. Oke, thank you. Satu lagi. Apa lagi? Oh, Christopher.
Darmais Cancer Center.
Yeah. 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 Yeah.
Our place.
The new building. That's it.
21 floor.
Pretty much.
Thank you.